Hello and welcome to lecture 70 of this series. The series is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I am Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. You can find my book on Amazon at the link below. We are still on Chapter 9, Metabolic Alkalosis. This is Part 4, Diagnosis and Management of Metabolic Alkalosis. We said previously that metabolic alkalosis is an increase in blood pH to over 7.45 due to primary increase in serum bicarbonate. When that happens, you have respiratory compensation. And this respiratory compensation is an increase in PaCO2. We also said that metabolic alkalosis is the most common acid-base disorder in hospitalized patients, especially in a surgical critical care unit. Let's discuss the diagnosis of metabolic alkalosis. First, you need arterial blood gas. To ascertain the diagnosis of any acid-base disorder, you need arterial blood gases. You don't have to get it every time, but you cannot say with certainty that this is the diagnosis unless you have arterial blood gases. So to establish the diagnosis of metabolic alkalosis, you need two things. You need blood pH above 7.45, and you need elevated serum CO2 or high serum bicarbonate. High serum bicarbonate can also be seen in metabolic compensation for respiratory acidosis. Therefore, in and of itself is not enough to make the diagnosis of metabolic alkalosis. We suspect metabolic alkalosis in someone with vomiting, diuretic use, licorice use, cystic fibrosis, exogenous use of bicarbonate, or someone with a history of primary aldosteronism. Physical examination is very helpful in differentiating metabolic alkalosis associated with volume contraction versus volume expansion. Now, like I said, most of the time clinicians make the diagnosis in the appropriate clinical settings, such as overdiuresis, NG suction, vomiting, physical exam, some basic chemistry profile, without resorting to arterial blood gas. What laboratory testing we need? Well, we just talked about arterial blood gas. We need a basic metabolic profile, basic chemistry profile. We need to know the sodium, potassium, chloride. Of course, magnesium is very helpful and it's critical to obtain it and replace it if it's deficient. Urea and creatinine are helpful in evaluating renal function. What about urine electrolytes? Well, we're going to look at urine chloride. If urine chloride is 20 or above, then we have extracellular fluid volume expansion. Below 20 millimole per liter, you have extracellular fluid volume contraction, and this is usually the case. Contraction alkalosis is much more common. Now, like I said, it's not enough to look at the sodium because many times it's elevated due to the excretion of sodium with the bicarbonate. Now, we don't need to do a 24-hour urine collection for chloride. You can just do a random urine specimen for chloride. We need additional laboratory testing depending on the case. If we are suspecting primary aldosteronism, this is a big deal. Then you need renin and aldosterone. Maybe you do a suppression test. Maybe you do a 24-hour urine for aldosterone, etc. Surreptitious diuretic use is a common cause, an important cause of metabolic alkalosis. If you see urine chloride and sodium, sometimes it's high, sometimes it's low, you should suspect diuretic abuse. You can order a urine diuretic screening and it's available and it's confirmatory. If you are suspecting a genetic disorder like Barter's, Gittleman's, 11-beta or 17-alpha hydroxylase deficiency, you need to consult a specialist, of course, and you need genetic testing. What is Pendred Syndrome? I mentioned that this may come up on a test. Maybe it is important if you are a pediatric nephrologist. If you're an adult nephrologist, chances are you'll never see it. Pendred Syndrome is an autosomal recessive disorder characterized by deafness and thyroid goiter. We have a mutation in the SLC26A4. This gene encodes pendrin, and pendrin is that chloride bicarbonate exchanger found on the beta intercalated cells. So if there is a problem with it, then bicarb is going to stay in and chloride is going to go out. Now, this pendrin is expressed not just by the beta intercalated cells of the cortical collecting duct, it's also expressed by the thyroid glands, inner ears, and this is why you get the deafness and the thyroid goiter. Normally, patients don't have much problems because they compensate by other ways, but if they get dehydrated, especially if you are treating them with a thiazide diuretic, they can get a life-threatening metabolic alkalosis. If you use thiazide with acetazolamide, you're really adding fuel to the fire. You get profound cell wasting because acetazolamide downregulates pendrin. So keep this in mind in case you get a test question, someone doing okay, all of a sudden they have some underlying deafness, maybe a goiter, then you give them a thiazide and things go downhill. So keep that in mind. What are the manifestations? Most patients with mild or moderate metabolic alkalosis are asymptomatic. Up to a serum bicarbonate of 240 is tolerated. The manifestations are usually due to concomitant hypokalemia, hypophosphatemia, hypomagnesemia, hypocalcemia, hypoventilation, dehydration, etc. Metabolic alkalosis decreases ionized calcium. If you have severe alkalosis bicarbonate over 45, you can have tetany, seizures, and arrhythmias, even delirium. Alkalemia also inhibits respiratory drive and shifts the oxygen-hemoglobin dissociation curve to the left. How do we manage it? I really want you to take two things, okay? For most patients with metabolic alkalosis, unless they're fluid overloaded, you need to give them saline and you need to replace potassium and magnesium, okay? Keep that in mind. Don't give just D5W, it doesn't work. Don't give half normal saline. Give isotonic saline, 0.9 normal saline, okay? And replace potassium. You replace it orally and intravenously. Sometimes you do both depending on the clinical scenario. Okay, this applies to chloride-sensitive metabolic alkalosis, or in other words, contraction alkalosis, or in other words, metabolic alkalosis with ECF volume contraction. Now, when you do that, you are going to restore volume, and the kidneys are going to do the work for you. The kidneys are going to get rid of the sodium and bicarbonate and restore acid base. If you have low magnesium, replace it. Okay, that will help your potassium case. Diuretics should be discontinued, or at least the dosages should be lowered. If you have someone with heart failure, liver cirrhosis, and you cannot discontinue the diuretics, consider adding spironolactone, eplerenone, amiloride, or triamterene. I never liked triamterene. I use the other three to combat hypokalemia and hypomagnesemia. Acetazolamide is bicarbonate. It has a limited role in the management of metabolic alkalosis. I see a role for it in someone who is fluid overloaded, and you cannot give them fluids. You have to continue diuretics, they're in heart failure, and you have to use acetazolamide. Now, it is very chaluretic, and hypokalemia is going to worsen metabolic alkalosis. So when you use it, you must check potassium daily. Okay, you must check BMP, basic metabolic panel, basic chemistry profile daily. It should be used by experienced clinicians. I usually write 250 to 500 milligrams 2 to 3 times a day, orally or intravenously, but I put a limit. I put for 2 days, 3 days. I don't want to put a patient on it and then leave for 3 days and come back and see a severe hypokalemia or even metabolic acidosis. They did a study called the Diablo study. I don't know why they chose that name. It was in 15 intensive care unit in France. Maybe in France they don't know what Diablo is. Anyway, it involved 382 patients with COPD on mechanical ventilation, and they had pure or mixed metabolic alkalosis. In the active arm, patients were given acetazolamide, big dose, 500 to 1,000 milligrams twice daily, intravenously. The primary outcome, which was the reduction in the duration of invasive mechanical ventilation via endotracheal intubation or tracheotomy, did not change. There was a statistically significant small reduction in bicarbonate, only 0.8 millimole per liter in the acetazolamide group. So use acetazolamide, but not a lot. What about a patient with metabolic alkalosis and extracellular volume expansion? Well, we just talked about the use of acetazolamide. Those patients are chloride resistant, meaning if you give them 0.9 saline, it's not going to help. But you should still replace potassium. Here you have to know why they're in metabolic alkalosis and expansion. Are they in heart failure? Do they have liver cirrhosis? Then you focus on the underlying cause. If they have adrenal adenoma or bilateral adrenal hyperplasia, then you address that. Okay, adrenal adenomas usually are resected. Bilateral adrenal hyperplasia is treated with spironolactone or eplerenone. Now, in primary hyperaldosteronism, we use low sodium diet. We reduce the distal sodium delivery, and therefore we reduce potassium loss. Now, if you have someone on peritoneal dialysis or hemodialysis already, we can very quickly, very effectively correct metabolic alkalosis, just as easy as we correct metabolic acidosis. All we have to do is to lower the dialysate bicarbonate. Normally, we run patients on a dialysate bicarbonate of 35. We lower it to 30 or 30 or 32 easily, and we can correct the alkalosis. Continuous renal replacement therapy is also helpful. We change the bicarbonate in the replacement solutions or the dialysate, and we can correct metabolic alkalosis. In patients on chronic dialysis, we keep the bicarbonate in the dialysate around 35. Higher than that is associated with increased mortality due to post-dialysis metabolic alkalosis. We rarely, if ever, use hydrochloric acid. It should be placed in a glass container. You need a central venous catheter. It can cause severe hemolysis, venous thrombosis. Once pH is around 7.5, you have to stop it. IV tubing should be changed every 12 hours. Needless to say, it's a huge hassle. I've only done that twice in my whole career. You can also use, and I hope you would not, ammonium chloride. Ammonium chloride is metabolized into urea and hydrochloric acid. It is associated with central nervous system toxicity and gastrointestinal adverse reaction. You can give it orally. Arginine hydrochloric acid is no longer used because it can cause life-threatening hyperkalemia. It shifts potassium extracellularly. Actually, if you want to know about this agent, is so you know that it causes severe and life-threatening hyperkalemia, not to use it. So pretty much you're going to use 0.9 saline, replace potassium, replace calcium, maybe spironolactone in certain cases, acetazolamide in certain cases. Hydrochloric acid should be left to very experienced clinicians. Let's talk about certain situations. We should address the underlying diagnosis. So if someone is vomiting, we have to know why. If they stop vomiting, that will help a lot in correcting the metabolic alkalosis. So you give them medications to combat vomiting. Maybe you need to investigate, consult GI. Do they have peptic ulcer disease? Do they have gastroenteritis, etc.? Some patients may be helped with H2 blockers or proton pump inhibitors. If you use a PPI, really monitor magnesium, okay? Because here we're in a situation where magnesium may be already low and potassium already low. You add a PPI, monitor magnesium. If you have exogenous source of alkali, you should stop it. If someone is taking citrate or sodium bicarbonate tablets, it should be stopped. If someone is using licorice-containing tobacco products, especially some people get that from Europe, it should be stopped. Remember to ask about licorice. We have two syndromes, Bartter syndrome and Gittleman syndrome. They are treated, but Bartter syndrome is treated with potassium repletion. So you replace potassium, you give spironolactone and amiloride. And if their kidney function is well, you consider a non-steroidal anti-inflammatory medication. Why? Because this is a high prostaglandin state, so you block the prostaglandin effect. If you do that, of course, the patient should be under the supervision of a nephrologist, and you need frequent monitoring of renal function and liver enzymes, no less than every 3 months. Gittleman syndrome, same way, but Gittleman is notorious for magnesium deficiency. So you do all that plus you replace magnesium. In one study, they evaluated the use of indomethacin, eplerenone, or amiloride in 30 patients with Gittleman syndrome. This is very impressive. I don't know how they got 30 patients. Anyway, indomethacin was the most efficacious. It increased potassium level by 0.38 millimole per liter, followed by amiloride, followed by eplerenone. And 40% of the patients on the indomethacin discontinued treatment because, you know, it's awful. It causes a lot of gastrointestinal side effects, including ulcers and bleeding. So it's probably better not to use it. Now, we reached the end of this chapter. Let's talk about the key points. Metabolic alkalosis is the most common acid-base disorders in hospitalized patients, especially in a surgical critical care unit. The higher the pH, the higher the mortality. How do we get metabolic alkalosis? You need to gain alkali or lose acid, and then the kidneys should fail to excrete that excess alkali. So you need a generation phase and then a maintenance phase. Metabolic alkalosis can be associated with volume depletion, which is more common, or volume expansion. Volume depletion is chloride sensitive. It's treated with what? Saline and potassium. I'm not going to tire of that. Now, volume expansion is chloride insensitive, so you replace the potassium and you address the underlying cause. The molecular mechanism of several genetic disorders associated with metabolic alkalosis have been elucidated recently, such as Bartter, Gittleman, Little, and Pendred syndromes. I'm going to end here. In the next and final lecture on metabolic alkalosis, we are going to do some case studies. See you then.